Hey everyone, back to our channel. So today we're going to discuss our, we are going to continue our cardiac physiology. So today we are at, you can see the textbook heading and also our notes heading, the cardiac action potentials. So very interesting, very easy process. We'll complete it as soon as possible. So let's begin. So first we need to see some important terms as usual. So first we need to see what is fast action potential. So in the name you can understand that is like something fast potential. So it's like rapid depolarization due to opening of fast sodium channels. Very easily understood. Rapid depolarization means you always remember depolarization takes place due to positive ions influx into the cell. If you have seen my homeostasis, if you have seen my general physiology concepts, then you can easily understand this concept, right? So because of any positive charge, especially we take everywhere sodium, right? So here also we take sodium, especially we're taking the fast sodium because if the channels are very fast, then the sodium also comes rapidly more, so it leads to rapid continuous depolarization, which is nothing but forming the fast action potential. Very easy concept. To form a fast action potential, we always require depolarization and repolarization waves. So to form mainly the depolarization wave, we need the lot of sodium. That's it. So now let us see the pacemaker potential. So what is a normal pacemaker of a heart? Or everyone knows SA node is our favorite pacemaker of a heart, right? So this pacemaker potentials means what? It is also known as diastolic depolarization or prepotential. So very important point, pacemaker potential is also known as diastolic depolarization or prepotential. So what is diastole? Systole contraction, diastole is relaxation. We already discussed during the diastolic process of heart, the calcium goes back to sarcoplasmic reticulum mainly by means of our Serca pump. Actually, I also wanted to mention one of the difference between the skeletal muscle and cardiac muscle is that in a skeletal muscle, we always say that contraction of the skeletal muscle takes place because of the calcium which is mainly released from the sarcoplasmic reticulum. But here in the heart muscle, that contraction of heart muscle mainly takes place by the calcium which is released from the T tubules. So, in T tubules there is mucosaccharide which is negatively charged which holds the calcium. So the contraction in the cardiac muscle mainly takes place due to the calcium released from the T tubules but not from the sarcoplasmic reticulum, as we already seen in our skeletal muscle. So first remembering this point in your mind, now let us continue this pacemaker potential. So this is nothing but the diastolic depolarization means during the relaxation of the heart, that is when the calcium is going back to the sarcoplasmic reticulum. In that stage the depolarization which is taking place, that is also called as prepotential. So here what happens, that is this process is slow and increase in membrane potential to the threshold, the level threshold level that occurs between the end of one potential and start of another potential in a SA node. So it is between the two potentials, because after diastole, again systole should occur, so again the potential should start. So between the two potentials, where the threshold is reaching, seeing the increase in the membrane potential to threshold level that occurs between the end of one potential and start of another potential in the SA node, this is called as pacemaker potential. So why we call SA node as pacemaker, because it can cause its own action potential. How it can cause this is mainly by this process, because by the end of one potential only it will be again ready to put the level in the threshold, so that again the next potential will take place without any stop of heart beating. So this is what, so that's why it is called diastolic depolarization, because at the end of heart rate means at the end of relaxation of the heart, again depolarization should take place and start the action potential. So if you understand the concept, it will be very easy process. So now let us see what is slow action potential. As we seen fast action potential, you can understand because of opening of fast sodium channels there is rapid depolarization. Then what is slow action potential? They have slow upstroke because of influx of calcium under a lower amplitude and the slower conduction than the fast action potential, and this is typically seen in SA node and AV nodes. So the only difference you need to remember that in the fast action potential it is mainly sodium dependent depolarization, because of sodium the depolarization always will be rapid. But in the slow action potential the depolarization is mainly depend on the calcium. So remember that calcium influx also leads to the threshold, also lead to the formation of action potential, but that is the slowest one when compared with the fast of the sodium. So this slow action potential is due to the calcium dependent depolarization. So this examples means in which process this slow action potential is seen, mainly in our SA nodes and AV nodes. So this is very important. And now let us see what are the two, now let us go into our topic, right? action potential. So how they are formed? So mainly we have two potentials. One is the slow potential, one is fast action potential. The slow potential is mainly seen in a pacemaker areas like SA node, AV node as we discussed, and the fast action potentials are seen mainly in contractile and conducting cells. So what are those contractile and conducting cells? Nothing but our Purkinje fibers in our ventricles, right? So they have fast action potential because of sodium dependent depolarization, and in the SA node and AV node we have slow potentials because of calcium dependent depolarization. So now let us move on to SA node. So SA node is actually small flattened ellipsoid strip of specialized cardiac myocyte. It is about 3 millimeter wide and 15 millimeter long and 1 millimeter thick, and this SA node is in it is present in superior posterior lateral wall of right atrium, below and lateral to the opening of SVC. So if I get the heart diagram, I will show you where actually our SA node. So you can see this is the SA node. So it is superior posterior. Yeah, it is located superior posterior lateral wall of right atrium, right? You can see below and lateral to opening of SVC, because this is a SVC. So below and lateral to opening of SVC. So that is the exact position of SA node, and there is no true resting membrane potential for SA node. This is important. There is no true resting membrane potential for SA node, and the lowest potential it has like about -55 to -60. That is its resting membrane potential. So actually in muscles the resting membrane potential is like around -90, right? But here in our SA node it is having lowest potential. Like about -55 to -60, it's the resting membrane potential. The reason for this it is always leaky to sodium and calcium ions, so that the positive charge always neutralize the intracellular negativity. You can understand this. So as it is always leaky, as our SA node is always leaky to sodium and calcium, you can understand. As it is always leaky, sodium and calcium are more extracellular in extracellular fluid. So because of concentration gradient, they tend to come inside. So as they are trying to come inside, always from -90, the resting membrane potential is moving towards like -55 to -60, because of this sodium and calcium ions present inside the cell. So there is no true resting membrane potential in SA node. So this is the reason why it doesn't have true resting membrane potential, because it may vary from -55 to -60, because we can't say that how much amount of sodium, how much amount of calcium comes. So according to that it changes. So whereas in ventricular muscle fibers, the resting membrane potential is like from -85 to -90, like all our skeletal muscle cells. So between the two heartbeats, the resting membrane potential becomes uh, less negative. Yeah. So between the two heartbeats, the resting membrane becomes less negative due to sodium influx, and when threshold reaches like about -40, the L type of calcium is close within 100 to 150 milliseconds. So this thing you need to remember. We have difference now with the skeletal muscle and the cardiac muscle mainly is that between the two heartbeats, the resting membrane potential is becoming less negative. That is, it is becoming more positive. Why? Because of influx of positive sodium ions. So as the sodium ions are coming, it reaches the threshold, right? So upon reaching the threshold, now new channel is getting open. That is our L type of calcium channel. So this L type of calcium channel open, but it closes only within the 100 to 150 milliseconds. Means only some amount of calcium is able to come inside now within this short time. So this channels activated and they cause the action potential. So this is how the action potential is mainly caused by L type calcium. Yeah, channels activated and cause the action potential. So the leaky nature to sodium and calcium cause the self-excitation in the SA node. So that is the reason why in SA node there is always self-excitation, because sodium and calcium, you can understand, if they are coming lot more, they can easily bring the cell to from resting membrane potential to threshold, so that it can easily continue the process of formation of this potentials. So the next process takes place as usual like our skeletal muscle. Next the potassium channels open and efflux occurs, like about potassium channels open about like 1/10 second, efflux occurs, and this results in excess negativity. But remember that this here the potassium channel is open for the long time. If it is closed immediately, you can understand it will come back to resting membrane potential. But as it is open for the long time, you can understand the cell becomes more negative because of potassium efflux outside and becomes hyperpolarized. So hyperpolarization takes place, and this carry the resting membrane potential to -55 to -60. And next again the RMP. So actually what happens, After this potassium efflux takes place, again after sometimes resting membrane potential is achieved, and after that the threshold becomes again -40, and this is caused by hyperpolarization. So remember that. So understand the process, same like our this is here SA node RMP. Once again let us review all the process because it's somewhat different from skeletal muscle. So in SA node the RMP is varying like from -55 to -60. The reason is sodium and calcium channels are always open, so it can't maintain its own resting membrane potential. And next what happens, sodium influx takes place, it undergoes threshold. So when it reaching the threshold, before reaching the threshold at -40 only, L type of calcium channels are also opening, but they close within like about 100 to 150 milliseconds. So next, however, the action potential is formed due to the positive charges inside. So next, after forming the depolarization, next repolarization should take place, but instead of repolarization here hyperpolarization is taking place because the potassium channel is open for the long time. So after hyperpolarization, to form the next wave of action potential, what happens is now this hyperpolarization only it leads to formation of opening of funny sodium channels, hence the name here funny sodium channels. It's not the normal sodium channel, because always normal sodium channels should open after the resting membrane potential, but here the wave is different. First depolarization, hyperpolarization, and from hyperpolarization to again leading to threshold. So here the wave is different. So hyperpolarization is causing the funny sodium channels to open, and it is leading the threshold to -40 and forming again the action potential. So that is the difference in the SA node and a normal skeletal muscle. So okay, we are done with that. Now let us see the fast action potential. So in the fast action potential, actually first RMP is like about -85, it comes to +20 because of positive ions influx, and later it forms a plateau. You can understand +20 means it has come to a threshold. Next it is forming a plateau. Plateau means, after depolarization what happens is the amount of calcium coming inside, the amount of potassium going outside will be equal, so that it forms a plateau. So plateau lasts for about 15 times long in the cardiac muscle. So hence we can say that it is prolonged. The refractory period and also the contraction of a cardiac muscle is prolonged mainly because of this plateau formation. And after the plateau formation, again the repolarization takes place. This is actually a format of a fast action potential. So before we have seen the SA node format, means there are different formats in a heart going on, you can see. So the long action potential and the plateau form due to the voltage due to fast voltage gated sodium channels. Yeah, this is important. Plateau is forming, and also this repolarization, all this taking, this is fast, right? In fast action potential, as we discussed, is due to fast sodium channels, right? And also L type of calcium channels, actually they are slow, lazy to open, and remain open only about 1/10 second. So in this time what happens is the calcium and sodium inflow takes place. So this maintains a prolonged depolarization and cause a plateau in action potential. Yeah, as we discussed that calcium, the amount of positive charges coming in and the amount of potassium going out will be equalized, so that it will prolong the plateau for some time. And calcium in this prolonged phase increase the contraction. Yeah, calcium is useful for contraction, so this is how there is prolonged contraction seen in a heart muscle, whereas in a skeletal muscle, from calcium comes from the sarcoplasmic reticulum and cause the contraction, but in our heart this calcium is mainly coming from our L type of calcium channels, or from, we can say that from the T tubules, right? Yeah, better than T tubules, you can say that from L type of calcium channel only. This is leading to contraction, but in skeletal muscle it is due to the sarcoplasmic release calcium. So next potassium, the potassium permeability decreases, that is increase in calcium influx by calcium channels. So later what happens? Potassium permeability decreases, means potassium outflow decreases and calcium influx increases by calcium channels. So decrease in potassium permeability leading to decrease in outflux of potassium positive charge during the plateau. So when L type of channel when L type of calcium channel closes at the end of 0.2 to 0.3 second, an influx of calcium and sodium stop and potassium efflux occur. So finally repolarization, and this process ends like, this is how the process ends. So this is the format which is taking place in a fast action potential. So mainly here the difference between skeletal muscle and cardiac muscle is that in the cardiac muscle we mainly find the L type of calcium channels which are leading to formation of plateau. So after plateau, again same repolarization takes place. So in a short form we can say first depolarization, plateau, repolarization, that's it. But in the case of SA node, first depolarization, next hyperpolarization, again going to threshold by funny sodium channels. Here we have L type of calcium channels. That's it. Now let us see the phase. Yeah, we have different phases, so this actually we need to learn by means of a diagram to understand it better. So okay, first we'll check out some diagrams from our textbook, and later we'll continue this process. So yeah, we are in this lesson. So first here we need to check out this. So there is a rhythmical discharge of a sinus SA node fiber. Also the sinoatrial action potential is compared with that of ventricular muscle fiber. So you can see the resting membrane potential, threshold for discharge, and depolarization takes place. Instead of depolarization, here hyperpolarization takes place. Again same process, depolarization, hyperpolarization. So in a ventricular muscle fiber, if you see there is a plateau. So remember that in SA node there is no plateau formation. But in ventricular muscle you can see first RMP. From the RMP it is coming to depolarization, forming a plateau due to L type of calcium channel is open, right? And after that going to again resting membrane potential. So this is a ventricular muscle. But the difference you can see in SA node we are having mainly hyperpolarization going on and also no plateau formation. So next diagram is here. So rhythmic action potential from a Purkinje fiber and a ventricular muscle fiber. So you can compare the Purkinje and ventricular muscle fibers. So in both, of course, you can see in ventricular and Purkinje fibers also plateau is seen. In ventricular fibers also plateau is seen. But remember that in Purkinje fiber the action potentials are faster when compared with ventricular fiber. So you can see it is like a peak, coming a peak, only some plateau again going back. But whereas you can see here somewhat the plateau is like somewhat long. Actually both in ventricular Purkinje fibers the conduction is fast when compared with our AV node and SA node. So here you can see the skeletal muscle, the temporal association between electrical blue and contractile red response in skeletal and cardiac muscles. So you can see here's the skeletal muscle. In the skeletal muscle, the blue means what? Electrical means action potential. In skeletal muscle, action potential shorts longer, but contraction is more. But in a cardiac muscle, they move side by side. You can see how the electrical potential is going on, and even the contraction, they go side by side, hand by hand. That is in the case of cardiac muscle. And here we'll see the phases of action potential of cardiac ventricular muscle cell. Yeah, these are the phases now we need to discuss. So phases of action potential of cardiac ventricular muscle cell and associated ionic currents for sodium and calcium and potassium. So here it's inside the cell, it's outside the cell. Outside the cell you can see potassium concentration inward, calcium, sodium. Yeah, that's what they're saying. For potassium you can understand, to go outward it is like opposite, because potassium is more inside the cell, so it is moving against concentration gradient. And for calcium and sodium, they should be outside more, but to move inside they should also move against concentration gradient. So here it is mentioned as I, that is the ionic current which is required to move against the concentration gradient. So that is about this graph. And now here we are going to discuss this last one. Yeah, there's no more diagram. So this last one we will discuss by this phases content, right? So now let us discuss this. So first let us discuss about our phase 0. You can see a 0. So this is a membrane potential, this is the time. So let us see. The phase 0 is called as depolarization, everyone know. So here what happens? Sodium channels open and depolarize, and the membrane potential becomes positive, and next the voltage gated sodium channel open and permit the sodium rapid inflow into the cell. So the membrane potential reaches now about like plus 20. So you can see here reaching about plus 20, right? Reaching the plus 20 before the sodium channels close. So it reaches plus 20 before the sodium channels close. So completed phase 0. Now move on to phase 1. Phase 1 is an initial repolarization. The fast sodium channels close and cells begin to repolarize, and potassium leave the cell by opening the potassium channels. So this is the phase 1. And next move into phase 2. Phase 2 is a plateau. You can see the plateau. So in the phase 2, the calcium channels open and the fast potassium channels close. Initial repolarization occurs and action potential plateau is seen, which is mainly result of increase in calcium ion permeability and decrease in potassium permeability. So the voltage calcium ions open slowly in the phase 1 and 0, and calcium enters the cell. So the potassium channels then close, and combination of decrease in potassium efflux and increase in calcium influx mainly causes this plateau. So that's what we're discussing. So this is like a complete summary for our discussion. Now let us see the phase 3. So in phase 3 you can guess it, it's nothing but repolarization, right? So rapid repolarization. Here the calcium channels close, slow potassium channels open, Closure of calcium channels and increase in potassium permeability outward permit the potassium ions to rapidly exit the cell and ends the plateau and return the cell membrane to the resting level or again to the resting membrane potential. So we have completed this. Next, the last one, fourth phase. The fourth phase is the resting membrane potential. It averaged like about minus 90 millivolts. That's it. So now let us see the sympathetic and parasympathetic effects on our heart. So as I already discussed, sympathetic means stress. So whenever you need stress, even our heart gets stressed, that is increase in heart rate. So mainly you know how this mechanism I already explained in our electrophysiology of heart, right? So sympathetic system mainly, once again let us review in a fast way. So sympathetic system mainly release the norepinephrine. Norepinephrine act on beta 1 adrenergic receptors by again I'll say no problem. It will act upon G stimulatory. So this G stimulatory, it has mainly alpha, beta, gamma units, right? So this releases means it break down the bond between beta and gamma. Now alpha alone, it will in turn have attached to GTP, and now it converts our ATP into cyclic AMP. So now this cyclic AMP will just produce the protein kinase A. This protein kinase A will phosphorylate our what it does. So this protein kinase A will phosphorylate the calcium channels, and now the calcium influx takes place. So increase in calcium inside the cell, increase in contraction of muscle, or also we can say increase in heart rate. So this is how it works on our heart. So that is the mechanism. I just simply I review it. And next, in AV node and AV burdens, there is increase in sodium permeability and increase action potential. So this leads to decrease in conduction time from atria to ventricle. Of course, if the action potential is more, you can understand. Only for less time only can easily pass the action potential. So calcium play very important role in exciting the contractile process of myofibrils. Yeah, we already know. So parasympathetic, P means for peace. So whenever you're in peace, even your heart wanted to be in peace, right? So here acetylcholine is released. Potassium ions efflux takes place when the acetylcholine is released by parasympathetic system. So hyperpolarization takes place, that is the cells become now less excitable. And in SA node, hyperpolarization decrease the RMP from minus 65 to minus 75 and decrease in rhythmic effects, and that is decrease in excitation. In AV node also there is decrease in heart rate, large decrease block conduction entirely. Sometimes it can also block the conduction entirely. So in parasympathetic system, actually the internal mechanism is it activates G inhibitory. So this G inhibitory in turn the same process continues, but here what happens is it blocks the calcium channels, decrease the calcium influx, so that decrease the heart rate. So that is the only difference. So once we will end up this video with the only important box from our textbook, right? So you can see here the effect of some drugs on cardiac action potential. Even in pharmacology we'll read it detailed, but now just we'll review it. So you can see the channel or receptor. For the sodium channel, the nature of the action is mainly blocking. The effect is reduce the maximum rise of action potential and decrease in conduction through the conducting system and atrial and ventricular muscles. And beta receptor is also blocker. It reduces the sodium, reduce the heart rate and slows the conduction. And potassium channel also blocker, prolongation of action potential duration. And calcium channel also blocker, depression of plateau phase of action potential and negative inotrophism. So here AV means atrioventricular, SA means sinoatrial nodes. With this we'll end our chapter of our cardiovascular physiologies, cardiac action potentials. Next we'll discuss this origin and conduction of cardiac impulse.